In Tune. Conversations on audiology and balance. An Inventis podcast.
Welcome everyone to this new and first podcast by Inventis. And on this occasion, for our 20th anniversary, we've decided to give you a gift. That's why today I'm here with Professor Vincenzo Marcelli, a specialist in audiology with a PhD in the physiology and pathology of audio-verbal communication. He is also a top-level professional and a consultant at the Audiology Department of the Federico II University of Naples. We are very happy to start this new initiative, and greetings to the professor.
Good evening, everyone. Hello to all.
Professor, how long have you been working in the vestibular field, and how did your interest in such a specific area of medicine begin?
Well, I've been working for over 30 years now, and as often happens, it all started completely by chance. Basically, the colleague who was in charge of Vestibology at the hospital decided to leave, so I found myself literally thrown into a world I knew absolutely nothing about. There were major difficulties at the beginning. We're talking about the years 1990, 1991, when the internet didn't exist. So finding papers and articles on the subject was really complicated. There were indeed very few available texts, and regrettably many of them were quite incomplete, so it was consequently quite challenging to adequately acquire sufficient and comprehensive knowledge. What helped me a lot was traveling around to various universities, especially Florence with Professor Pagnini, Dr. Giannoni, and then there were other institutions like Modena with the late Professor Guidetti, Marco Manfrina Pavia, Daniele Nuti a Siena, all people who have made history in vestibology in Italy.
Very well, it's also very interesting and quite insightful to know how modern technology has made a truly important contribution to being able to investigate diseases much further. So I think that in the 1990s it was actually much more complex and challenging. But now, just to put it in simple terms and focus a bit on the vHIT, I'd simply like to ask you, again in simple words, what is the vHIT, the video head impulse test? What information does it provide about the vestibular pathway? How is it performed? And also considering the different technologies used to carry out this test, and also taking into account the types of remote cameras compared to cameras that use a mask.
Yes, well, actually, there's been a rather unique and quite significant evolution. We initially went from an almost exclusively instrumental approach in the 1990s, just think of the detailed electronystagmography, to the truly revolutionary bedside examination, which still very effectively allows us to perform a precise differential diagnosis between peripheral and central lesions right here and now without any absolute need for complex instrumentation, and then finally to the significant advent of the head impulse test and thus the highly effective video head impulse test. It truly was a significant revolution because the video head impulse test made us realize just how unreliable the bedside examination can actually be, especially in those cases where we struggle to make a diagnosis, but above all, in chronic patients. Because while it's true that for acute patients, we have little need for additional instrumentation, for chronic patients, instrumentation becomes absolutely indispensable. The video head impulse test is a revolution, as I mentioned earlier, because it allows us to assess the individual function of each semicircular canal and therefore obtain an absolutely precise picture of the vestibular system's ability to stabilize images. Earlier, you thoughtfully mentioned the important topic of different equipment, and this is also very, very important precisely because we have this major difference between equipment that comes with a mask and equipment that operates with a remote camera. Obviously, the remote camera eliminates a number of issues, such as problems with the mask's fit, but above all, it is especially advantageous for examinations in pediatric cases. An examination in pediatric cases can be performed almost exclusively with the help of a remote camera.
This is very interesting, and in fact, I would really like to understand a bit more clearly. When we are talking about Estricos IDPs, is there a specifically recommended minimum age to obtain truly reliable and accurate results? If there is, what are the guidelines for these systems? And then, how can we obtain the cooperation of young patients, considering the various challenges that may arise during the examination?
Well, first of all, let's remember that the vestibular system is already mature at birth, so in principle we could perform a vestibular exam even on a newborn. The only problem is that the newborn must be able to focus directly on a target, because it is precisely by having them fixate on the target that as we rotate the head on the lateral and vertical planes, we are able to perform the exam. So in reality, I wouldn't talk about a specific minimum age. I would instead talk about the crucial ability to effectively capture the child's attention so that the necessary test can be successfully performed. It's abundantly clear that all of this essential process must take place within an environment that is genuinely comfortable and reassuring for the child. So it should be as familiar and welcoming as possible, perhaps with the delightful possibility of showing engaging toys to this precious little patient and then carefully attracting their attention in a more technical and precise way, according to the specific characteristics of the specialized tool we are utilizing, so that the child is truly able to follow the designated target even for just a few crucial seconds, giving them all the necessary time they need to eventually provide a definitive and accurate response.
The test itself is well known when performed on adults, but I imagine it must be very challenging to keep a child's attention. If we were to list the main challenges we encounter during vestibular testing in pediatrics, we could say that keeping the child's attention is one. But are there other things we need to take into consideration?
I would say yes, absolutely. As strange as it may initially seem, the one and only thing that truly becomes absolutely essential in this particular situation is the operator's unwavering patience. We, as operators, genuinely need to be present and fully able to effectively manage those specific periods when the child can actively and enthusiastically participate in the test. But at the very same time, it's even more critically important to skillfully handle those challenging times when the child simply does not possess that necessary attention span. So, in such instances, we thoughtfully let them play, perhaps give them a comforting toy, or gently distract them in some appropriate way until perhaps by utilizing different and varied targets, we are ultimately able to successfully recapture their valuable attention. So, in reality, it's not a technical difficulty, it's about how committed we truly are to following through with the test, and that makes all the difference in the world.
Great. I'd like to go even more in depth on this particular subject, thinking specifically about people who have never before seen a vHIT exam, especially when it's conducted in a pediatric setting. I'd like to ask, above all, what are the primary differences you've specifically noticed in the vHIT exam when performed on young children versus adult patients? On one hand, from a purely technical point of view, I mean specifically in terms of the established protocol or the precise procedure for conducting the examination, but also significantly in terms of interpretation, should we realistically expect precisely the same results, or should we genuinely anticipate quite different outcomes when comparing a 6-month-old infant, a 5-year-old child, and a fully grown adult?
Well, that's a question for which the answer isn't simple. Now, I'd like to make a very brief introduction. As happens with ABR and VEMPs, first and foremost, each of us should diligently develop our own individual assessment framework. This involves carefully studying children, observing their unique characteristics, and subsequently creating our own comprehensive and reliable reference points. Let me explain better. If we know that in adults an ocular VEMP has a latency of 10 to 13, just to give an example, this might not be the case in children, and so we first need to establish our own reference points. And the same goes for the vHIT, so we should first evaluate healthy children and understand whether there are actually any differences compared to adults. our experience tells us that essentially there is no difference. Obviously, a child's response might sometimes be very well executed and other times not executed at all. On the other hand, the machine we use allows us to actually evaluate the video of the recording. And if in that video we notice that the child has lost focus, not due to a pathology, because it becomes very clear whether the child loses focus because of a pathology or simply because they got distracted. And so let's say that the analysis is perhaps a bit more complex compared to adults because it may require, for example, eliminating certain responses that would clearly distort the picture. But I also want to point out something. We also need to understand what we mean by child, because thanks to this machine, when we talk about children, we're really referring to very young kids, as young as 8 or 9 months old. But even a 3-year-old child is already able to perform the test absolutely perfectly on all levels, with responses that are comparable to those of an adult. Because we know perfectly well that the vestibular system is the first system to develop during pregnancy, so the child is born with a fully formed vestibular system, and therefore we shouldn't expect any differences in the responses. And as a result, there is also no difference in the interpretation of the response. It is a response that, if the vestibular reflex with the humidifier works correctly, stabilizes the eye in space, and very importantly, unlike other machines, this machine tells us not only that the eye is stable in space, but it shows us any small deviation from the 0 position that we consider the normal one. So it also gives us much more detailed information about where the eye falls and whether the eye remains in that position, which, for example, other machines do not do.
I would say that this point is very important in terms of the technology being used, precisely as we started this podcast by saying that in the past it was a very different challenge. Today, with technology, we are actually able to carry out an even more in-depth analysis. But on a purely technical level, the significant technical difference, I mean specifically in terms of precisely positioning the target or having an assistant provide crucial support during the actual exam, how exactly would you thoroughly explain the fundamental differences between an adult patient and a young child? I can certainly imagine it's not quite the same for a very young 6-month-old infant or a 2-year-old toddler as it is for a 5-year-old or even a 10-year-old, correct? Of course.
Well, obviously, if we start with adults or older children, for the older child, you can give the clear instruction to keep their gaze fixed intently on a certain target. And even though they might make a minor mistake on some tests or some rotations, basically, with a very clear and precise instruction, the child is generally able to follow it quite well. The significant challenge with much younger children is that they can easily lose their focus, and we really need to be skilled at effectively regaining their attention. For example, if we use a light stimulus, we can turn it off and then maybe after a few seconds, a minute or 2 minutes, turn it back on, and this recaptures the child's attention. Or we can effectively change the target, so first use one particular stimulus, then another. Or, for example, we can utilize videos that the child is already accustomed to watching, and this approach could certainly help to regain their valuable attention. As I was saying, in reality, we don't have a standard protocol. It depends on the skill and, above all, the willingness of the operator to complete a test that can last 3 minutes or even half an hour.
When it comes to younger children, in these cases, is it necessary to have the support of parents or someone else to help the child during the exam?
Of course, it's clear that if we're talking about involving the child in a familiar environment, nothing is more helpful than having the test done with the child held in their mother's arms. The operator positions themselves slightly behind, the child focuses on the target, and the test is carried out. I repeat, there may be some difficulties, but we've performed exams on children as young as 12 or 13 months in just a few minutes, because at that moment the child was willing to pay attention to the target being shown. So a familiar environment and, above all, making the child feel comfortable.
I imagine it's really important for the child to feel at ease and relaxed so that I can follow the entire exam without losing focus on the target. Very interesting, in fact. Thank you very much for this fascinating topic. I'd like to shift for a moment to the important topic of pathologies and the possible deficits that we may encounter, especially within the pediatric field. I would simply like to ask, for which pediatric vestibular disorders can we benefit the most from using the vHIT as a diagnostic tool?
Here we're opening up a whole new world. I mean, apparently the pathologies that affect adults are more numerous than those that affect children. It's clear that we'll never find a baby just a few months old with Meniere's disease. It's much more likely that we'll find one affected by an acute vestibular deficit, and yes, I assure you, it does happen. Generally, my advice whenever we talk about vestibology is to never start from what you expect, but always from what you see, from what you find, because starting from preconceived solutions can be very misleading. And here there are truly some extremely important things to keep in mind. The very first example I'll give, if we want to talk about pathology, is a young child who is a bit slower in their developmental milestones, a child who is just over a year old and is very clumsy in their movements, who falls quite often, a child, for example, who strangely can't manage to ride a bike. Well, these are all children who need to be carefully evaluated because they might have a vestibular deficit, which, contrary to what people think, is not something they compensate for more quickly just because they're young. In fact, it's exactly the opposite. In order to compensate for a deficit, I need to have, for example, fully developed cerebellar structures. So I can assume that an adult compensates quickly, but a child who doesn't have a perfectly developed cerebellar structure will have a much harder time compensating. But there's another extremely important aspect. For example, we now have reasonable certainty in saying that children with congenital hearing loss very often have an associated vestibular deficit and they are not screened for it. And this is extremely serious. Why? Because just as we screen all newborns at birth, we should screen not only children at risk, and by children at risk we mean those with a hearing disorder, but also all other apparently healthy children, precisely because vestibular disorders are not visible. However, vestibular disorders are fundamental when it comes to primary skills such as language, reading, and writing. By now, we are certain that a child with a vestibular disorder experiences a significant slowdown in their development and learning. And this is why, early and above all, universal screening is so important. I'll conclude this point by reminding you that, while in children we face this serious difficulty, in adults, a chronic vestibular deficit that goes unrecognized or untreated leads to emotional disturbances in 30 to 50% of patients. Chronic develops anxiety and depression, but above all, it affects a range of cognitive abilities such as memory, attention, and concentration, all aspects that the patient does not associate with a vestibular deficit, but which we, thanks to this equipment, can detect even when our patient appears to show no signs of distress.
No, this is really very, very interesting indeed, because let's just say that the path of pediatric treatment is often overlooked. People say that children don't need to be studied or followed because the main focus is placed on adults, but the pediatric field is often neglected. For this important reason, I would like to ask whether it can be considered truly important, very important, or even absolutely essential to perform a comprehensive vestibular exam like the vHIT in the pediatric field.
No, as I just mentioned, I believe it is essential. I can give a very simple example. One of the last children we saw was born with a cytomegalovirus infection, had bilateral hearing loss, received a cochlear implant, so he had a cochlear implant on the left side, and the vHIT showed us a severe right labyrinthine deficit. Now, this child cannot be left on his own. He needs to be stimulated. And keep in mind, stimulating such a young child is not complicated. All you need is a mobile, a swing, a trampoline, a floor. I think everyone has a floor at home where you can roll the child a bit to the right, a bit to the left, have them jump on a trampoline, put them on a swing, both in the front-back direction and side to side. And these are all extremely simple activities, but they play a fundamental role in supporting the child's recovery. And pay attention, here we have another crucial aspect. When we are faced with a child with a learning disorder, whether or not there is a vestibular issue, vestibular activity becomes essential. That is, it has been proven, and let me give you a very simple example in Kazakhstan. Probably not even the mothers know why they do it, but in Kazakhstan, children with Down syndrome are subjected to intense stimulation. The mothers literally take them in their arms and spin them around in every possible way you can imagine. What has been shown? It has been demonstrated that children with Down syndrome who undergo this kind of stimulation, thanks to it, have significantly higher cognitive abilities than children who are not subjected to this treatment. So vestibular stimulation acts like a key to unlock the cognitive abilities of these children. And naturally, if this is true, and it is, just imagine what it means to carry out vestibular stimulation activities with children who have learning disorders. And keep in mind, we're not talking about rare phenomena here. We're talking about something that affects about 8% of children. So just imagine what it means to find a fun way for the child, like through play, or telling them to ride a bike with an incredibly significant result in improving these abilities.
This Kazakhstan thing is completely new to me, and I think for many people it's not well known, so it's very interesting. I think I'll look up more about this topic later. If we go back to the examination of the video head impulse test and also elsewhere, when talking about rehabilitation and patient follow-up, how could the vHIT be integrated into the follow-up and vestibular rehabilitation process in the field, somewhat in pediatrics?
Yes, this too is a complex aspect in the sense that obviously if we are faced with a child with a deficit in one or more semicircular canals, everyone's hope is to promote the recovery of canal function, in this case, so that the reflex returns to normal. Unfortunately, this does not always happen either in adults or in children. So what is the purpose of rehabilitation, which in this case becomes re-education? Well, it serves the same purpose as the exercises we try to use to promote the recovery of that receptor which is not functioning properly. In reality, if this receptor is no longer able to recover its function, the same exercise becomes a way to re-educate the system, allowing the system itself to function as well as possible, even with a malfunctioning labyrinth, by teaching the patient how to make use of the other inputs, namely the visual and proprioceptive ones. So you see how, in the end, a comprehensive 360-degree assessment of the patient is necessary, whether they are an adult or a child, keeping in mind, without going too much into detail, that nowadays vestibular rehabilitation, like any type of rehabilitation, must be carried out with the patient playing an absolutely active role. It has been shown that if I perform vestibular rehabilitation on a patient without activating what is called the central executive network, that is the cognitive structures responsible for making decisions, if we do not rehabilitate by also engaging these systems, and this has been demonstrated that the outcome is significantly worse. So it's a complex task, I'd say only apparently so, but one that must take into account a series of aspects, sometimes even quite far removed from what seems to be just a vestibular system, which, as we now know, no longer has only a role in maintaining our balance, but plays an extremely important part in many other activities. Just as an example, the posterior lobe of the hippocampus in taxi drivers is much more developed than the posterior lobe in bus drivers, and the only difference between the two is that taxi drivers, by constantly taking new routes, stimulate the vestibular system, which is directly connected to the hippocampus and spatial memory, and as a result, this hippocampus becomes larger. Bus drivers always follow the same route, so this mechanism doesn't occur. So you see how the simple act of using different information leads to a huge reorganization in the brain, which in this case manifests as an increase in the volume of the hippocampus.
Thank you, Professor, for all these very different insights that are making us develop a passion for vestibulology. I'd like to ask if you could tell us about a clinical case that particularly struck you, where the vHIT played a decisive role in the diagnosis or treatment of the patient?
Well, yes, let's just say it was indeed truly quite a very particular case. In the end, we were only able to reach a definitive conclusion thanks to the vHIT. It's the story of a 12-year-old boy thoroughly assessed by a colleague from Calabria who called me and said, "Look, I saw this boy about a month ago. He had a well-documented acute vestibular deficit. But I'd like you to take a look at him because now I don't see any more signs. I wouldn't want something to show up on the WIT that I'm not seeing. But the really serious thing about this child is that now he can't stand up anymore. I mean, literally, he can't stand up." The boy comes to my attention, and indeed he walks with extreme difficulty. He has to be helped by his parents. When I see such a complex situation, among other things, I try to have the boy write something, and the writing is absolutely illegible. So I start to investigate a bit more thoroughly. Obviously, I expect something significant to come out of the vHIT, but in reality, the vHIT is absolutely perfect, as is the rest of the vestibular exam. So, thanks to the vHIT results, I began to shift my attention to extravestibular phenomena and mechanisms. I started talking with the parents a bit, asking, but Giuseppe, that's the boy's name, but Giuseppe, what does he do? What doesn't he do? Does he like going to school? And the only thing that comes out of this story is that Giuseppe really doesn't like going to school. Any excuse is good enough to avoid going. In fact, it's been over a month now since he's gone to school. At that point, I signal to the father to leave with Giuseppe, and I speak with the mother. I say, "Look, right now Giuseppe doesn't have any symptoms, so let's try to really understand what's happening at school. Maybe it's just a trivial refusal without any real meaning, but let's assess carefully what's going on." It seemed like that was the end of it. The next day, the mother sends me a video of him running around the house, as if he had unlocked himself in this respect. But after 2 months, the same problem reappeared, and at that point, the parents continued to investigate, and unfortunately, it turned out that I don't want to go into specifics, but unfortunately it turned out that there were very serious problems at school, not just bullying, but also other situations. So it became clear, maybe we would have figured it out anyway, but who knows how much later, that thanks to a careful assessment of this child, we were able to rule out an organic cause and focus on a completely different kind of issue.
Of course, about other factors that can sometimes be very helpful for us to clarify things and to rule out all the possible cases that could be vestibular in nature and investigate other possibilities. I'd like to ask one last question. In terms of advice, what would you suggest to someone who is approaching the field of pediatric vestibology and wants to learn more about using the vHIT? After everything we've discussed today, I find it very interesting because now there are more ways to get informed. There are also videos available on Academia, on Inventis, and on the internet, as well as various webinars. How could someone, or what advice would you give to someone who wants to approach the field of pediatric vestibology?
Well, that's a question that really resonates with me. It resonates with me a lot because, as I mentioned earlier, my training was very complex. Now, there's the academy, there's the internet. I remember that back then, if I needed an article to study, I had to go to the library. Once I got to the library, I would order 3 articles, and maybe after 2 months, one of them would arrive. Now the world has completely changed. Vestibology is an extremely fascinating subject. I have a series of shirts that I use at the office, and one of them says on the back, "Vestibology is addictive." Why is that? Because it's a subject that grabs you, that fascinates you, that has 1,000 facets, and the same pathology is 1,000 times different in 1,000 different patients. How can we get people interested? I believe you need to be in contact with your colleagues. You need to show them what we are capable of doing, what can be achieved. By understanding 8 to 10 concepts of pathophysiology, a few years ago, I wrote a book. And I mention it now for just one reason. Perhaps the most beautiful thing about the book is what Pagnini, an incomparable master, wrote in his preface when he said, "You can tell that the author doesn't write for himself but for others." I think that's the most beautiful thing that I truly wish I could hear that said to me, because for me, it's a real and profound need, sharing what I know is a truly fundamental part of my professional work. So I strongly encourage my colleagues to actively attend the comprehensive courses and masterclasses we'll be offering, because I firmly believe that only by thoroughly discussing theory and practice in the field can new and insightful perspectives open up, making one become truly passionate about vestibology.
Thank you very much, Professor. The message is that knowledge shouldn't stay within the clinic, but should be shared. Professor Vincenzo Marcelli, thank you again for these extremely valuable answers and for your time. I invite everyone to follow the upcoming podcasts, which will cover various topics on audiology and also on balance. So, thank you all for your time and see you soon.
Thank you, everyone.